Hello coders! Today we're going to be going over integumentary surgery from your CPT book. So we're going to be following along in my guideline pictures, but before we do that, at the first page that you'll see in the document uploaded into your course will give you this information. For each and every section of surgery, there are different ways that we can look for different types of procedures. But there's three main terms, okay? Name of the surgical procedure, like mastectomy, okay? Or rhytidectomy. Name of the anatomic site. Again, in this case, it's going to be stuff like skin or nails. Or the name of the condition, like a Polynomial cyst or, a debridement. So again, we always want to keep this in mind. So these are different integumentary surgery main terms that we're going to see as we go through. And so everything, again, we start with the easy, most common integumentary main term is skin, because that is what the integumentary system is mostly made up of. Remember, the integumentary system is made up of the three layers of our skin, our hair, and our nails. So when we are dealing with skin, we not only need to know the procedure, most of the time we need to know anatomic site. Where on the skin is the actual problem? So always come back here to help you for your main terms for these procedures. So the first part is what we call introduction and removal, and those are things like incision and drainages of things like acne and abscesses and hematomas. Those don't have any specific guidelines on page 75. But when we turn to page 76, this is where we start to see information about our debridements. So debridement is cleansing and cutting of the skin. It could be done because of burns. It could be done because of traumatic accident or injury. It could even be done for an infection of a wound. So again, these wound debridements, as they tell us, are reported by the depth of tissue that is removed. So how far into the body are we going? And the surface area of the wound. So again, that's the length times the width. So most of the time what we're going to see here is everything is going to be in centimeters. First of all, metric system for surgery, for the entire medical system. But also, again, certain things are just going to be in length, like wound repairs are going to be in length. How long was the cut on the person's arm? Versus debridements are going to be in area. How large was the section? This is up to the doctor to tell us. So keep that in mind. So they could tell us, I did 10 square centimeters. Or they could say the area was 2 centimeters by 5 centimeters, and we would have to multiply them to get 10 square centimeters. Now, these services are reported for injuries, infections, wounds, and chronic ulcers. When performing debridement of a single wound, report depth using the deepest level of tissue removed. We need to know how far into the body are we going. Now, because debridement always starts in the outer layer, the epidermis of skin, we need to know, is it epidermis, dermis, subcutaneous tissue? But because of the nature of debridement codes, we're also going to see things for fascia, muscle, and bone. So how far into the body are we going there? Now, one of the things that happens in integumentary surgery is we have a lot of math that happens in small parts. So this is why we always go back to our guidelines to tell us what to do. So if it's a single wound, we report the deepest level of tissue removed. In multiple wounds, we can sum up the surface area for wounds that are of the same depth, but do not combine sums from different depths. So if we have two wounds that both go into the dermis, we can add them. But if we have a wound that goes into the dermis and another into the subcutaneous tissue, those will have to be coded separately. And again, remember, the depth is how far into the body are we actually going for these. So, excuse me. I do want to point out, though, for the debridement codes, you will notice the code 11000 and 11001 are specifically for eczematous or infected skin, and they are by percentage of the body. So again, be careful. Most of the time, it's going to be in centimeters length or centimeters area. However, sometimes they're going to be by percentages, so keep that in mind. Now, the big issue with paring or cutting. So there are no guidelines for paring or cutting on page 77. Paring or cutting is exactly what it sounds like. We are removing something from the skin, but we are not in any way cutting into blood vessels. So these are going to be things like corns and calluses on the feet and the hands, things like that. And so again, if we're doing a debridement, we can look up debridement as a main term. If we're doing paring or cutting, we can look up paring or cutting. Where we have to be careful is the next set, which is the biopsy. As you can see, I've written always included in a larger procedure, always. So again, they tell us that during certain surgical procedures in the integumentary system, such as excision, destruction, or shave removals, the removed tissue is often submitted for pathologic examination. The obtaining of tissue for pathology during the course of these procedures is a routine component of such procedures. So again, the obtaining of tissue is not considered a separate biopsy procedure and is not separately reported. So this goes for all of surgery. Unless we are destroying the tissue by doing a destruction procedure, we are always going to send a piece of tissue or sometimes tissues to pathology to confirm whether or not the tissue is benign or malignant, okay, cancerous or not. But if all we're doing is the biopsy, then we can use this code, and that's what it tells us. To use the biopsy procedure codes 11100 and 11101 indicates the procedure to obtain tissue for pathologic examination was performed independently or was unrelated or distinct from other procedures or services provided at that time. So for instance, if they are removing a cyst on somebody's back, okay, we're going to take a portion of that cyst and we're sending it to pathology. That is not these codes. But if while we're removing that cyst from the person's back, the doctor sees another suspicious spot they would like to biopsy, then we can code for these. So again, we always have to think about what is included in a larger procedure. And again, these are by each and every lesion. You'll notice as we go through, a lot of what I've highlighted in the code descriptors are the differences in the codes, because some of them, again, are going to be by length, some by area. In this case, we're going by each and every lesion. So what this means is, if we're biopsying 3 lesions, we would use code 11100 times 1 and 11101 times 2, so that we get 3 lesions altogether. Remember, we can never use add-on codes by themselves. Now, skin tags, as you can see, this is a scissor removal of skin tags. They tell us that removal by scissoring or any sharp method, ligature, strangulation, electrosurgical destruction, including chemical destruction or electrocauterization of the wound, with or without local anesthesia, and that's what it includes, okay? So the inclusion here is the local anesthesia. So if the doctor wants to inject a little anesthesia under the skin tag so the patient doesn't feel it, we cannot code separately for that. But again, be careful. 11200 is up to and including 15 lesions. And then 11201 is each additional 10 lesions or part thereof. So even if we do 16 lesions, we still have to use 11200 and 11201. Okay, and again, when we're talking about these, so this is the scissoring. They can also use different types of scalpels, ligature strangulation when they tie a piece of surgical string around it. Electrosurgical destruction is when we're using usually hot heat to destroy it as well. And so again, this can also include the what we call chemical destruction or electrocauterization of the wound. The electrocauterization of the wound, especially for things like skin tags, they look like pens. And at the end of the pen, it's actually a little laser and it can seal up those capillaries. Okay, so that is included in this as well. We cannot code separately for those. Now, let's talk a little bit about what shaving is, okay? So they tell us shaving is the sharp removal by transverse incisions or horizontal slicing to remove epidermal and dermal lesions without full thickness dermal excisions, okay? This includes local anesthesia, chemical or electrocauterization of the wound, and the wound does not require suture closure. So sometimes what we want to do is we want to just shave off the lesion itself. Sometimes we do this with warts, but we have all different types of lesions where shaving it, which again, we're going across, we're cutting across. And what we do is, again, we're not suturing this. We can seal it with the hot electricity pens or with a chemical that will stop the bleeding. And again, this is going to be depending on the lesion that the patient may have. So we kind of have to keep this in mind. There's lots of different lesions out there. Lesions includes everything from pimples to cysts to abscesses. It also includes different types of possible skin cancers, different types of growths that can be something that is of a disease process or not. Basically, when you hear the word lesion, it's something that's not supposed to be there. Okay, that's the main thing you want to keep in mind. A lesion is not supposed to be on the skin. Now, because this is skin, we have to be careful. First of all, again, if we're doing something like a shaving, we need to know not only where is it on the body, but how large is the shaving. So what we would look up is we'd look up in the back of the book, shaving, skin lesion, and then we need to know. So code 11300 is for the trunk, arms, or legs. And then as we go up numerically, we go up with how wide the diameter of this lesion is, okay? So we have 11300 that includes trunk, arms, or legs. We have 11305, which includes scalp, neck, hands, and genitalia. And 11310 that includes face, ears, eyelids, nose, lips, and mucous membranes. So again, we separate these out by anatomic site as well by how large, in this case, the diameter. So the largest point between the widest area of that lesion. Now, again, the shaving, we're not cutting in and scooping out, we're just slicing, okay? Excision is doing just that. Excision is going in and a lot of times going under the lesion to remove it, because a lot of lesions like cysts, all the different types of cysts, they have sacs. And if we don't remove the cyst sac, it can regrow, because basically at the bottom of the cyst sac is a little root that's attached to the connective tissue that's surrounding it. And what happens is if you don't remove that, it can regrow. So sometimes instead of doing an incision and drainage, where we just puncture and squeeze out whatever is inside of a lesion, or instead of shaving it, we do a full-on excision. Now, the biggest thing with the excisions is it a benign or malignant lesion? When it comes to the field, it is perfectly acceptable to hold that surgery for a few days until the pathology report comes back, because you don't want to code it out as benign when it was malignant or vice versa. Rebilling, especially when making a coding error, because remember, coding a benign instead of a malignant and vice versa not only affects the procedure code, it will also affect the diagnosis code. So we want to kind of keep that in mind. So it's okay to wait for the pathologist to come back to confirm whether or not this is normal tissue. So what is excision? Excision, which includes simple closure of benign lesions of skin. So benign lesions of skin can include benign neoplasms, benign cicatricals, which are scars, fibrous, inflammatory, congenital, and cystic lesions. And this includes local anesthesia. So they also can do this for different types of congenital conditions that lead to large patches on the face being miscolored and things like that. But a lot of times these are done for different types of lesions that need to be fully removed. So the excision itself is defined as a full thickness through the dermis, removal of a lesion including margins, and includes simple non-layered closure when performed. Okay, so again, these are lesions that are going through the dermis to at least the top of the subcutaneous tissue. It includes the margins, which we're going to look at in a minute. So what we do when we remove a lesion is we always make sure we're giving enough space, just in case that tissue is cancerous, that maybe we captured all of it at once. Okay, report separately each benign lesion excise. Each lesion excise gets its own code no matter whether or not it's benign or malignant. Now, code selection is determined by measuring the greatest clinical diameter of the apparent lesion plus the margin required for complete excision. So lesion diameter plus the most narrow margin required equals the excise diameter. Now, most of the time, the doctors will just give us the excise diameter. Why? Because in general, they have to know about how wide they want to make the incision at the beginning. However, they can give us the size of the lesion, size of the margins, and make us do some simple math. That is completely normal. The last thing that I want to say before we actually look at the margins is this at the beginning of this paragraph. The closure of defects, so areas that don't have enough skin or tissue there, created by incision, excision, or trauma, may require intermediate or complex closures. Repair by intermediate or complex closures should be reported separately. And we'll talk more about that when we get to the wound repair codes. So again, if we can't just push the skin back together and suture it, then we may have to use a secondary code to describe multiple layers or a complex set of sutures for that patient. Okay, so we're going to look at this and then we're going to go back to the guidelines. So this one is on page 81 in your book. So again, the lesion right here. So the lesion right here is 0.2 centimeters. The margin the doctor made on either side was 0.1 centimeters. So we're going to add 0.1 plus 0.2 plus 0.1, which gives us 0.5 centimeters, okay? Because we have to add up both of the margins plus the diameter at the same time. But again, they have to either give us the entire diameter of both the margin and the lesion, or they have to give us both the diameter of the margin and the lesion so that we know how to calculate this properly so they get the proper reimbursement. Now, one of the things that you'll notice is that underneath all of our benign lesion excisions, we again have different anatomic sites. So light code 11400 is for trunk, arms, or legs. 11420 is scalp, neck, hands, feet, and genitalia. So again, remember, when we're looking up lesion excision, you can look up skin and then lesion. You can look up lesion excision. We need to know anatomic site, where are we removing this from? And we need to know how large the excise diameter is. And by the way, that is both for benign and malignant lesions, okay? So the benign lesions are pretty straightforward, okay? So you code for each and every lesion. Malignant lesions are very similar, but there's a couple of other complications we need to keep in mind. So again, they remind us that excision, including simple closure of malignant lesions of skin, again, most common are things like basal cell carcinoma, squamous cell carcinoma, and melanoma, includes local anesthesia, okay? So again, a lot of these are including simple closure, so one layer of sutures, and local anesthesia, injecting underneath or around where we're excising, okay? Again, excision is defined as full thickness through the dermis, removal of a lesion, including margins, and simple non-layered closure when performed. report separately each malignant lesion excised, and then it reminds us again that we always need to know the greatest clinical diameter plus the margins for the correct code. However, starting down here, so this is the bottom left-hand side of page 81. When frozen section pathology shows the margins of excision were not adequate. So again, frozen section pathology is while the patient's still on the table, we're sending down a piece of tissue to pathology to confirm whether it's benign or malignant, okay? So if the margins of the excision were not adequate, an additional excision may be necessary to complete tumor removal. Use only one code to report the additional excision and re-excisions based on the final widest diameter required for complete tumor removal at the operative session. So if the patient's still on the table, they have not left the operating room, we go to pathology. Pathology says, nope, there's still cancer, and we make the wound larger to capture more of that cancerous tissue. Okay, we only code the largest or widest excision we have made, okay? But if the patient goes to the recovery room, if they're sent home, if they go back to their hospital room, and we find out that we have to do a re-excision at a different surgical session, that's where this comes in. Append modifier 58 if the re-excision procedure is performed during the postoperative period of the primary excision procedure. It takes pathology anywhere from a few minutes up to about 3 days to run pathology, depending on exactly what we're looking for. And so this is all going to be well within the surgical package. So keep that in mind, okay? So again, we can see here, we have 11600 separate out by trunk, arms, and legs. Again, 0.5 centimeters or less. And then underneath it, it continues. So again, don't let the pictures throw you off. You know, if you want, you can make a little, symbol or a little highlight to remind you the codes continue underneath the picture. So again, for lesion excision, we need to know 3 things. First thing we need to know, benign or malignant. Second thing we need to know, total diameter of lesion plus margin. Third thing we need to know is anatomic site, okay? So we need to know whether or not it's cancerous, we need to know how large it is, and we need to know where it is on the body, and that way we can match up our codes. Then we get to our nails. Again, a lot of people forget about nails. There are no guidelines for nails, but there are some different procedures that you should know about. Again, we have trimming for nails. Again, podiatrists do that all the time. We have a lovely picture of the nails and what we do. We have the debridement of nails. Again, that could be maybe someone who got into a traumatic accident and has gravel or dirt or even motor oil under their nails. We can do avulsion of the nail plate. And so again, what we're doing here is we are either removing part of the nail for things like ingrown toenails, or we're removing the nail entirely because maybe it was going to fall off anyways. We can also do an evacuation of a subungual hematoma. This is when you get a blood collection underneath your fingers. Again, more traumatic accidents and injuries, fingers being slammed in the doors. We also have the biopsy itself, a repair, and a reconstruction. So again, keep in mind when it comes to nails, your main term is going to be nails, okay? And then what are we doing to the nail? Then we have a little small section on page 83 for Polynomial Cysts, okay? These are cysts that happen in the polonial area, which is in the lower back. It happens about right above the sacrum. Right like on top of the sacrum, I should say. What happens is these can start as very tiny lesions, and in just a couple weeks, they can get absolutely huge. It gets very painful. It pushes on the spinal cord and the nerves, and they do have to be excised. So let's talk about repair closure. So again, When we were looking at the lesion removals, it told us that we may have to use another repair code because the removal or excision of benign and malignant lesions only includes simple repair. Well, what happens if we need to use more than a simple repair? This is why we have these codes. These codes are also used for any other type of wound closure, but as it says, utilizing sutures, so that's our stitches, staples or tissue adhesives, which is like a liquid Band-Aid. And we can use these either singly or in combination with each other or in combination with the adhesive strips. However, wound closure utilizing adhesive strips as a sole repair material should be coded using the appropriate E&M code. So if all they're using is adhesive strips, that's E&M only, okay? They have to be using something else to be able to use these wound closures. So we have three definitions, okay? We have simple, we have intermediate, we have complex. So as they tell us, simple repair is used when the wound is superficial. So it's involving the primary epidermis or dermis or subcutaneous tissue without significant involvement of deeper structures and requires simple one-layered closure. Again, this includes local anesthesia and chemical or electrocauterization of wound not closed. So again, think of a simple repair as one layer, one set of stitches, okay? An intermediate repair includes the repair of wounds that, in addition to above, require layer closure of one or more deeper layers of subcutaneous tissue and superficial non-muscle fascia in addition to the skin. So again, it goes on though. Epidermal and dermal closure. Single layer closure of heavily contaminated wounds that have required extensive cleaning or removal of particulate matter also constitute an intermediate repair. That's why I wrote 2 layers or contaminated wounds. And again, a contaminated wound, it could be gravel, it could be sand, it could be oil, it could be you name it. It could even be porcupine quills, but it's a wound that has other things in it that we need to cleanse more thoroughly. And so that bumps it to an intermediate repair. We get paid a little bit more. It's a little bit more complex, a little bit deeper into the skin. The complex repair includes the repair of wounds requiring more than a layered closure, things like scar revision and debridement for like traumatic lacerations or avulsions. You have a picture of an avulsion in your textbook. An avulsion is basically when the skin gets ripped away, from the actual body parts. This happens in a lot of like motorcycle accidents and things like that, where maybe a limb gets stuck, and so it literally gets ripped away. Again, this is something that's for very, very complicated repairs. Okay, so how do we know how we're supposed to code these? So the first thing that we absolutely need to know is we need to know how large it is. So number 1 tells us the repaired wound should be measured and recorded in centimeters, whether curved, angular, or stellate. So again, a lot of wounds are not straight wounds. They could be jagged, that's the stellate. So we want to keep in mind the doctor has to record the centimeters for us. So we need to be able to identify the centimeters, okay? Then what we need to know is, again, so that's how long. We also need to know where on the body it is, okay, what anatomic site it's on, and what's the complexity, okay? So again, we need to know, is it simple, intermediate, or complex? So if we have 2 different wounds, 2 totally different wounds, and they're both in different classifications. So the classifications are the simple, intermediate, and complex. We just code those completely separately, okay? And I'll talk about modifiers in a minute. But when there are multiple wounds that are repaired, we're going to add it together, the lengths of those in the same classification and from all anatomic sites that are grouped together in the same code descriptor. So that's where this notation comes up.